Buenas tardes, soy Sabrina Herrera. Les damos la bienvenida a nuestra actividad académica de la tarde de hoy, 23 de agosto de 2021. Tenemos con nosotros al doctor Jaime Mejía, quien muy amablemente nos ayudó a contactar al doctor Bruce Wennick, quien nos va a hablar de neoplasias de tiroides y las nuevas clasificaciones. Bienvenidos, doctor Mejía.
Gracias, doctora Sabrina Herrera, y gracias a la Asociación de Patología de Colombia, a la Asociación Colombiana de Patología. El conferencista de hoy nos ha aceptado una invitación, es una persona con autoridad internacional en el tema que vamos a tratar, en cabeza y cuello. Es el doctor Bruce Wennick, ha estado con nosotros en algún evento en el pasado también, visitándonos en Medellín, él va a hacer su presentación en inglés, pero como tenemos también otro grupo de personas en cierto número que nos visitan desde otros países para este evento, vamos a hacer una introducción en inglés, y de las preguntas y todo el proceso lo va a moderar la doctora Herrera. Dr. Wennick is, you know, he was the lecturer for the speaker for the 𝒕𝒉𝒚𝒓𝒐𝒊𝒅 lecture in 2021. He's the chairman and senior member of the Department of Pathology at Moffitt Cancer Center in Tampa since 2016. And he studied anatomic and clinical pathology as resident at Mount Sinai Medical Center in New York. That was in the 80s. Then he went through a long journey in the academic field, and then as a staff pathologist in the Department of Otorhinolaryngology, Head and Neck Pathology and Endocrine Pathology, and the FIP, the Armed Forces Institute of Pathology, the Temple of Pathology, for 11 years. In 1998, he became director of anatomic pathology and vice chair in the Department of Diagnostic Pathology and Laboratory Medicine at the Beth Israel Medical Center and St. Luke and Roosevelt Hospital, New York, were chairman there from 2014 to 2018 when he went to Moffitt Cancer Center. He has written more than 130-something articles on the subject. He's been the author or co-author of chapters in more than 80 or almost 85 books, and the single author of 3 books on the subject also. One of them is the Atlas of head and neck pathology that we recommend. You can get it in any bookstore, in Amazon, and so on. So he's a well-known and acknowledged international authority on the subject. Thank you, Dr. Bruce Wennick, for having accepted our invitation. It's our pleasure and my privilege to present you and having you here among us again.
Thank you, Dr. Mejia and Dr. Herrera, for the invitation. It's an honor to be able to participate in this lecture. As you can see, what I plan on doing is have a discussion over the next hour or so about an update on neoplasms of the thyroid, but reviewing criteria to make a diagnosis. So, as you may or may not know, the current WHO book is under revision for endocrine and neuroendocrine tumors. The publication date is supposed to be in 2022. And I just wanted to share with you briefly over the next few slides some of the changes in classification that is undergoing and will be published in this book. So among the categories that will be described are developmental abnormalities. The benign follicular epithelial-derived lesions or tumors is listed here. Some of the nomenclature has varied a little bit from the past, but basically the same adenoma categories as before, including one with papillary architecture. And then a broad group subcategorized under low-risk neoplasms to include NIFP, thyroid tumors of uncertain malignant potential, and hyalinizing trabecular tumor. There's not enough time to cover all these entities, but through my talk, I will be touching on some of these entities. And of course, the follicular cell-derived malignant neoplasms, which includes follicular thyroid carcinoma, the somewhat confusing terminology of invasive encapsulated follicular variant of papillary thyroid carcinoma, which is really a RAS mutated neoplasm that's akin to follicular thyroid carcinoma. And I'll spend a little bit of time of this because it's related to NIFP, and then papillary carcinoma, oncocytic carcinoma. And rather than use the term poorly differentiated thyroid carcinoma, the classification is going to change to follicular-derived carcinomas high grade. And I'll briefly touch on that. And of course, the tried and true anaplastic thyroid carcinoma. And then just to round out the picture, although we won't have time to talk about medullary thyroid carcinoma, and a group of rather uncommon, but nonetheless thyroid-based neoplasms varying from mixed medullary and follicular tumors that have morphology similar to salivary gland tumors, those that are considered uncertain histogenesis, and then thymic-related tumors, and a rather rare embryonal type of neoplasm, thymoblastoma. So that in broad scope is the updated classification to be published in the WHO sometime in 2022. What I'd like to do over the course of this time is discuss the diagnostic issues and terminology changes relative to follicular pattern thyroid neoplasms. And within the scope of this, also approach the diagnostic criteria for malignancy in thyroid follicular lesions and neoplasms. As you know, as has been established from quite a long time, the diagnostic criteria for malignancy in thyroid neoplasms includes invasion. So if you're a low magnification, as I will show you, and you see a tumor that you perceive to be infiltrative, it is malignant. Of course, you need to go to cytomorphology to make a diagnosis, but invasion in and of itself is diagnostic for malignancy. Cytomorphologic findings, particularly in trying to make a diagnosis of papillary thyroid carcinoma, the presence of mitoses and necroses, and may correlate to high-grade histomorphology, and of course, metastatic disease. And because we only have about an hour or so, I will only approach in detail invasion and cytomorphologic findings. Before I do that, I just want to remind everybody that the immunostaining for thyroid in general is helpful in the diagnosis of follicular pattern lesions or follicular-derived neoplasms of the thyroid. And the single best, most specific and sensitive, and no other cell in the body is immunoreactive for thyroglobulin. So if you had only one stain to do to try to prove that you're dealing with the thyroid follicular epithelial-derived tumor, it is thyroglobulin, because there's nothing in the differential that reacts for thyroglobulin other than follicular cell-derived neoplasms. Yes, thyroid transcription factor 1 is immunoreactive follicular-derived tumors, but it's also diffusely immunoreactive in C-cell-derived neoplasm like medullary thyroid carcinoma, or if you have a metastatic tumor, TTF1 won't differentiate a thyroid-based lesion from perhaps lung adenocarcinoma. PAX8 is a very sensitive and specific marker in thyroid neoplasms, particularly for anaplastic thyroid carcinoma, where among these three stains, PAX8 is typically retained, but not always. And that might be the only discriminator in an undifferentiated malignant neoplasm that may be cytokeratin also negative, that's indicative of anaplastic thyroid carcinoma. And if you didn't know, CD56 is a beautiful marker as seen here for thyroid follicular cells. And I caution you, relative to thyroid and non-thyroid lesions, that CD56 has no specificity and is not sensitive for any particular neoplasm. If you think it's a specific marker for neuroendocrine tumors, you're wrong. The best markers for neuroendocrine are not CD56, but synaptophysin, chromogranin, and INSM1. So these are the markers that we can deploy in helping us make a diagnosis of follicular-derived neoplasm. Of course, if you see something that's making colloid, it's a differentiated thyroid neoplasm, you may not need immunostaining. But just to repeat what I said before, the single most specific and sensitive marker for thyroid follicular-derived tumors is thyroglobulin. So we move on to the criteria, and the first thing we'll deal with is invasion. Invasion includes tumor capsular invasion, angioinvasion, or vascular invasion, whichever terminology. These are synonymous. You can use either one. Invasion into the thyroid parenchyma and extrathyroidal extension. The criteria are straightforward and simple in terms of their definition, But if you deal with thyroid, there's a lot of contentious issues about what may be or not be capsular invasion, what is and what's not vascular invasion, and what may or may not be extrathyroidal extension. So just from a gross perspective, you can see this lesion. The thyroid is nearly completely ablated. Its tumor is extending into muscle. So from a macroscopic or gross standpoint, this is a C clinical T3B lesion, and the clinical staging correlates to the pathologic staging. So if we're aware clinically, and we're not always aware of that, that a tumor has invaded into skeletal muscle in the neck, and it's clinical T3, then from a histologic perspective, which we might not see in the slides that we have, it also equates to a PT3. The PT3 no longer correlates to minimal or microscopic extrathyroidal extension. So if you see that, you might note it in a narrative, but in synoptic reporting, it does not equate to a PT3 any longer. That's a change in the 8th edition of the AJCC classification scheme. And then CT3 or PT3 tumors are divided up into T3A, which is more than 4 centimeters limited to the thyroid, and B, in which there's gross or macroscopic extrathyroidal extension into strap muscles in the neck from a tumor of any size. Here is the trachea, and it's invaded by a tumor that originated in the thyroid. That's a T4A neoplasm. T4A, as defined here, is extension beyond the thyroid into subcutaneous larynx. Trachea is evident here. Esophagus, recurrent laryngeal nerve, and it's of any size. And then there's a further subdivision into T4B, which is more extensive invasion, including prevertebral fascia or encasing large vessels, including the carotid artery. So from a clinical perspective, it's easy to determine the T3 and the T4 lesions. But generally what we deal with as pathologists are the limited invasion macroscopically, if you will, or those lesions that look circumscribed and encapsulated morphologically or grossly, and histologically may prove otherwise. But in this particular instance, this is not a needle tract. This is tumor that's actually violated the capsule and has invaded into the adjacent, or looks like it's invading into the adjacent thyroid parenchyma. And histologically, on the left, there may be vascular invasion. I just show it to you just as a low magnification schema to go back to what I originally indicated, that if at low magnification, you'd see a tumor that's encapsulated with invasion either through the capsule, as seen here, into the thyroid, or perhaps into vascular invasion, then by definition, that's carcinoma, to be further defined by the cytomorphologic features. Here at low magnification is a papillary carcinoma. It not only has papillary architecture, but it has the nuclear features of papillary carcinoma, but it's invasive beyond its encapsulation into the adjacent thyroid parenchyma. So again, reaffirming, if at low magnification you see any thyroid lesion that may or may not be encapsulated, that might be circumscribed but with invasion, then it's a malignant neoplasm. If it's follicular derived, then it's either going to be a follicular thyroid carcinoma or perhaps papillary thyroid carcinoma. The issues that we often deal with are the circumscribed or encapsulated lesions that do not necessarily on a macroscopic level indicate that there's any evidence of invasion. These are the lesions on an FNA, if it's not papillary carcinoma, that we cannot discriminate between an adenoma and a carcinoma. So just purely on the basis of a macroscopic evaluation, whoops, the differential, and I apologize, but I went all the way to the end of this presentation. I'll just scroll back.
No worries.
No worries. I don't know how that happened. That's rather unique. So where are we? Right here. So the differential is a nodule, a follicular adenoma, could be a carcinoma based on whether there is or is not invasion, and based on the nuclear features and perhaps immunohistochemical staining, could be follicular thyroid, papillary thyroid carcinoma, or even medullary thyroid carcinoma. So a diagnosis of follicular thyroid carcinoma relative to differentiating from adenoma is predicated on capsular invasion, with or without vascular invasion, with or without invasion into the adjacent thyroid parenchyma. So in its defining terms, it's a rather simple concept. But generally speaking, it can be problematic from pathologist to pathologist, or even among pathologists, in trying to determine what is and what's not capsule invasion. In general, discriminating follicular adenoma from follicular thyroid carcinoma, which have identical nuclear features or cytomorphologic features, not possible by fine needle aspiration, because we're pulling cells out and there's no indication or ability to evaluate for invasion. So capsule invasion, the extent of the invasion can be contentious. Any degree of invasion into the capsule, some people has defined as minimally invasive follicular thyroid carcinoma. As Dr. Mejia indicated, I trained into AFIP. In AFIP, my mentors were very aggressive in the diagnosis of capsule invasion. So any kind of undulation into the capsule was often defined as capsule invasion, and hence a diagnosis of carcinoma. I don't believe that that's an appropriate evaluation. The extent of invasion needs to be beyond that. Whether it needs to be full thickness or not, that's another issue that's under contention. But generally speaking, if the tumor has violated the entire capsule, then it's indicative of malignancy, and there's no special stains that's going to allow us to make that diagnosis. What's generally used is Dr. John Chan's schema for presence or absence of capsule invasion, as you see in this depiction, which is also used in the CAP protocol and in AJC staging. It has some indicators of when it is capsular invasion and when it's not capsular invasion. So those little undulations, as I described before, that might have been diagnostic for my mentors at AFIP for carcinoma or capsular invasion, rightly so, should not be considered capsular invasion. On the other extreme is full penetration of the capsule is, I think, for most of us, if not all of us, diagnostic for carcinoma, and there's great reproducibility of that. Unfortunately, not all of these lesions follow this schema, and on occasion you might see extension into the capsule that's less than full thickness, and then it becomes a little bit of a contentious issue whether it is or it's not. And according to Dr. Chan here, where the arrow is, it's not as yet capsular invasion. And then one could argue that, and I'll show you some images of that. So here are depiction of full thickness violation of the capsule. Here's a thin capsule. There's mushroom-like protrusion, another one where muscle-like protrusion where it has violated the entire capsule. This may be the only nidus or focus for capsule invasion, but one focus like this is diagnostic for capsule invasion. If there's no vascular invasion, then this is a minimally invasive follicular thyroid carcinoma. And just to correlate to Dr. Chan's schema, both of these images show complete violation of the capsule. And here's another example. It's a very small lesion, if I recall, is about 1 centimeter, but nonetheless had this mushroom-type protrusion bifurcating the capsule, which appears as shoulders on each side of the neck of this protrusion. So this is sufficient in and of itself to confer a diagnosis of capsular invasion and a diagnosis of follicular thyroid carcinoma, assuming that there are no nuclear features of papillary carcinoma. So here's some other examples that could be the subject of variable diagnoses among pathologists. Is this capsular invasion? It's still a little bit of capsule here, so it's penetrated most, but perhaps not all of the capsule. And here's another one where, if I bring up Dr. Chan's schema, shows what he considers not yet. And this is now a lesion that has grown into the capsule. There's maybe a little bit of the fibrous capsule along the periphery, but now it's moving back along itself, and in fact has reached the level of a blood vessel. So to me, I know this is contentious relative to his schema. If I see this, that is sufficient for me to make a diagnosis of capsular invasion. I might be concerned for vascular invasion. There wasn't any here, so could not confirm the presence of vascular invasion, but supportive for capsular invasion. What about this? Here's the capsule. Maybe this is a reactive fibrosis, But for now, we have to take this for being the entire capsule, which is rather thick. And here it's maybe a third of the way through, so not sufficient for a diagnosis of capsular invasion. So some examples where it's clear-cut and others where it's less clear-cut and could be the source of debate among pathologists. I just want to remind you that most of the thyroid lesions, the initial diagnostic modality is fine needle aspiration. There may be needle tracks associated with that prior traumatic event in which there's a suggestion that there may be capsular invasion. Here's the lesion. It was a follicular neoplasm. Here's a little bit of the cells of that lesion, but at higher magnification, this part of it, which is really through the capsule, is just histiocytes and macrophages, and those are inflammatory cells. So that's an FNA, post-FNA tract, not to be misdiagnosed as capsular invasion. I just want to take a few slides in defining a capsule because it's important when dealing with reactive fibrosis, in which the fibrosis may create nodularity, and the nodules may be in either side of the fibrous septae, suggesting the possibility of capsular invasion. So what I try to do is evaluate the quality of the fibrosis surrounding a given lesion and make a determination whether I think that's a capsule or reactive fibrosis. So these definitions are taken right from Robbins, which is a basic pathology, just indicating that benign tumors grow and expand slowly, and they develop a fibrous capsule. The capsule separates the tumor from the normal parenchymal tissue. In our discussions, the thyroid parenchyma. The encapsulation doesn't prevent tumor growth, but keeps that lesion confined and therefore unlikely to metastasize. So what I like to look for is uniformity in thickness, whether it's completely around the lesion, it retains its thickness more or less without marked variation in its thinner and thicker areas, and in higher magnification determine whether there's an orderly or disorderly arrangement of the capsule, of the fibers. So if you look here, you can see that there's good uniformity in thickness, and in high magnification, the fibroblasts are more or less oriented in parallel, so there's no variability either in thickness or in the growth of the fibroblasts. Another example of a slightly thicker, a little bit thinner here, but more or less uniform in thickness, and in higher magnification, perhaps a better representation of the fibroblasts, pretty much in parallel. So the orientation is good, the thickness is consistent, it circumscribed the entire lesion, and that to me is a true capsule of a tumor. Problems in thyroid pathology relate to sectioning. There may be a lack of orientation, creating irregular contours, which may lead to confusion in how to interpret a given area along the periphery. The presence of thick-walled blood vessels in a capsule may distort the sections and lead to artifactual changes that suggest invasion. In irregular fibrosis, there may be nodules on either side of the fibrous tissue, suggesting the possibility of capsular invasion. And when one sees this, and when you see a capsule nodule lying outside the capsule, multiple sections may be helpful in seeing if there's continuity and therefore violation of a capsule and perhaps representing invasive carcinoma or not, and maybe these are just multiple adenomatoid nodules. So case in point, in this one particular field, you could see this, what appears to be a circumscription, if not encapsulation, of this follicular lesion lacking nuclear features of papillary carcinoma, and the fibers are more or less in parallel. So, you know, by itself in this one image, this would appear to be a true encapsulated lesion and perhaps therefore a true neoplasm, and then differentiating adenoma from carcinoma is predicated on invasion. But in other areas, there were tangential section, and it happened to be a cellular nodule that lacked complete encapsulation. Focal areas that, as I showed you, looked encapsulated, but other areas in which this irregular appearance suggests that maybe there's permeation of a capsule with invasion beyond it. But if you look at the fibers here, they're irregular. They're thinner and thicker areas. They're in the lesion. There's no good orientation. This is all from the same case. This lesion was aspirated. These are oncocytic cells, which are more prone to traumatic change. There's cyst formation, and you can appreciate the irregular fibrosis and the absence of what I showed you before that constituted a true fibrous capsule, meaning that there's no good uniformity in thickness and there's haphazard arrangement of the fibers there. So to me, this is not a capsule, but a regular fibrosis, so that when I start seeing nodules on either side of this lesion in which there's cyst formation and hemorrhage, suggesting the possibility that maybe this is the main mass and this is infiltrative lesion, this is just a nodule with a regular fibrosis, not only around the lesion, but within the lesion, and perhaps not 100% consistent, but generally speaking, a true capsule of a true neoplasm remains on the periphery and doesn't extend in and out of the lesion as you see here. So these are indicators to me that this is reactive fibrosis, and in this particular instance happened to be an adenomatoid nodule with retrogressive changes likely secondary to the prior FNA, not to be mistaken for invasion and invasive carcinoma. The more reliable of the criteria is angioinvasion or vascular invasion, and the vessels that are involved need to be in the capsule or beyond. So if the lesion or the cells permeate a vessel within the tumor, that's not considered vascular invasion. The vessel should have an endothelial lining. Optimally, we should be able to visualize that morphologically and confirm it with the immunohistochemical stainings of your preferred endothelial marker. It could be CD31, CD34, or 𝒕𝒉𝒚𝒓𝒐𝒊𝒅. 𝒕𝒉𝒚 is a good nuclear marker of endothelial cells. And tumor cells protruding in a vascular space or bulging into it and endothelialized, in most people's view, represents vascular invasion. Other authorities hold to the need to, as I will show you, have an associated fibrin thrombus. Sometimes it's problematic identifying the vessel because the tumor has completely stuffed itself in the vessel and ablated any identifier of the capsule, and that becomes a challenge in terms of determining whether there is or not vascular invasion. Here's another schema from Dr. Chan, which is pretty much utilized in multiple texts, including CAP and AJCC, in which he depicts what is and what's not vascular invasion. Now, I'll go through some of these images, but if the vessel involved is in the tumor itself, then it's not considered vascular invasion. If it's free-floating, devoid of fibrin thrombus, it's not considered vascular invasion, but it is if it's with fibrin thrombus. If it's endothelialized, at least for Dr. Chan and for most authorities, it's considered to be vascular invasion. Doctors Mehta and Asa, in a 2011 publication, in an enormous number of cases they reviewed, of which 118 they used for follow-up, they developed strict criteria that the tumor cells not only need to be in the vessel through the vessel, but there has to be adherent intravascular tumor thrombus formation. I'll show you some examples without that it's hard not to call that vascular invasion. So while there is rigid criteria published by Doctors Mehta and Asa, there's some flexibility in that, and one can make a diagnosis of vascular invasion in the absence of fibrin thrombus formation. Just to reaffirm the complicated issue, it's simple to describe vascular invasion. It can be rather contentious in determining what and what is not vascular invasion. Case in point is the CAP protocol, in which D, which is endothelialized without fibrin thrombus formation, is, according to the definition in the CAP protocol, a judgment call. So that if there's no fibrin thrombus, some authorities would not call that vascular invasion, others would. It's under your general judgment, and in my view, I would always call that vascular invasion, even in the absence of fibrin thrombus formation. So some examples: here's tumor that's, here's the main mass. Tumor has infiltrated into its capsule directly into an endothelial line vascular space with fibrin thrombus formation as identified here. I think everybody would agree that that's angioinvasion with fibrin thrombus. Another example of the same. And here you could see here tumor in a vessel, endothelial line with fibrin thrombus formation. Here's another example that there's no fibrin thrombus formation. It goes back to that same image I showed you before, where the tumor violated the capsule and started growing in parallel and reaching a level of a intracapsular blood vessel, but there was no vascular invasion. Here's an example, and that image was a not yet for Dr. Chan, or at least in his schema. But here's the main mass, and here's the capsule, and the tumor has bifurcated the capsule and has gained access. It's endothelialized. There's no fibrin thrombus, but to me, and I think many people, that equates to angioinvasion in the absence of fibrin thrombus formation. Another example where the tumor is adherent to the wall, no fibrin thrombus formation. That to me is vascular invasion or angioinvasion. And yet another example, here's the tumor. There's no good capsule here, but the tumor has extended into the capsule. And here is a blood vessel lying outside the confines of the mass in the capsule. And here, nice CD31 immunostaining, both of the endothelial lining and the endothelialization of the tumor within or protruding into the vessel that equates to angioinvasion without fibrin thrombus formation. Another example, I don't think anybody should have a problem with this thick-walled blood vessel. Here's the tumor, separated by follicular normal parenchyma, but the tumor has gained access to this thick-walled vessel. Here's another one where it's near completely ablated. So I'm not showing CD31 or any immunostains, but I hope you can appreciate the fact that this is endothelial lined. However, there are examples where you see these well-rounded nodular nests of tumor outside the main mass. Here's one, and here's another one, that it appears to be so smooth contoured that it should be in some kind of space like a blood vessel. But there's no way to identify an endothelial lining in this, whether it's by elastic stain or by immunostaining. So is this or is not vascular invasion? And this is problematic. To me, this is at least capsular invasion. So by definition, it should be a follicular thyroid carcinoma. And the areas are worrisome for angioinvasion, but I can't prove that, and therefore cannot affirm the presence of vascular invasion. Here's tumor floating in a vascular space. Is that angioinvasion? It's not, and that equates to what I showed you before. Free floating, whether in Dr. Chan's schema or in the CAP protocol. When it's free floating, it's not vascular invasion. Here's another example of a tumor that's clearly in an endothelial line vascular space that's nearly completely replaced the blood vessel, where there's still retention of an endothelial lining. So is this angioinvasion or not? So location is important in real estate, but also where that vascular space is. And this blood vessel was right within this lesion, not outside the lesion. So therefore, as I showed you before, does not equate to vascular invasion, even though it's well within a blood vessel proven by endothelial markers. So this is not angioinvasion. Before we move on, I just wanted to review the classification of follicular thyroid carcinoma. So there's minimally invasive, and minimally invasive follicular thyroid carcinoma is only if there's capsular invasion. Any vascular invasion, even a single blood vessel, is no longer considered minimally invasive follicular carcinoma. On the other hand, even if there's more than 4 blood vessels involved, it's still within encapsulated angioinvasive and not widely invasive follicular thyroid carcinoma. Widely invasive follicular carcinoma means an invasion widespread in the thyroid parenchyma and many blood vessels. So even if you have 4 vascular spaces that it's involved, it's not widely invasive. So follicular thyroid carcinoma, minimally invasive, capsular invasion only, excellent prognosis, no metastasis, and essentially cured, no disease-associated mortality. Less than 4 vessels, excellent prognosis, good long-term survival, low mortality. More than 4 blood vessels, a less favorable outcome, where now you have almost 6 times a percentage in terms of mortality, and widely invasive, which is clearly a much more aggressive, and these are differentiated. They're not poorly differentiated anaplastic. in which it has an unfavorable outcome with mortalities ranging from 30 to 50%. So how many sections is enough? There's no standard. Many years ago, there was an international workshop on thyroid pathology. In an encapsulated follicular neoplasm, take at least 5 sections. Most people do 1 section per centimeter if there's of tumor. If there's low cellularity, large follicles, edematous stroma, and no invasion, then one can feel comfortable with follicular adenoma. And if there's increased cellularity or finding suspicious, then take more sections here. This recommendation is 5. There's no standard. Try to exclude the possibility of invasion and therefore diagnosis of carcinoma. A very busy slide, but this is one of the new classifications, if you will, in the WHO book, the uncertain malignant potential. And I tell you up front, I have never used uncertain malignant potential because, and I've told this story before, you know, when you are face to face with a surgeon or an endocrinologist or a medical oncologist and you tell them it's a thyroid lesion of uncertain malignant potential, they kind of stare off as if, you know, you're orbiting Pluto. They want to know if it's benign or malignant. So my view and my practice, and I'm not saying this is the standard, not nearly the standard, I try to make a diagnosis of benign and malignant. And if it's not malignant, then to me, it's an adenoma. Sometimes people use the term atypical follicular adenoma. The WHO does not recommend it. They do recommend using follicular tumor of uncertain malignant potential or well-differentiated tumor of uncertain malignant potential for those tumors that are encapsulated or unencapsulated but circumscribed, and which there are questionable features for invasion, whether it's capsular and or vascular invasion. You know, you need to use your own judgment, but in these lesions, there should be no invasion, whether capsular or angioinvasion, no nuclear features of papillary, no high-grade features such as increased mitoses, and that's, you know, 3 to 5, and now I think the standard is 5 mitoses per 2 millimeters squared and no tumor necrosis. If you see a high mitotic rate and necrosis, it may fall within the follicular carcinoma of high-grade morphology. And then molecular, as we will discuss a little bit later, is becoming more and more relevant into diagnosis, even including benign lesions. So in these uncertain malignant potential or atypical follicular adenoma, or for me, follicular adenoma, there's typically RAS mutations of one kind or another, up to about 40%. On occasion, can have E1, F1AX, and PAX, 8 PPAR gamma rearrangement, but P53 and TERT promoter mutations are generally indicators of a high-risk lesion. And if you have that and there's not definitive evidence of invasion, then it's worthwhile putting more sections through to try to determine whether there's clear-cut evidence of invasion. Just to review briefly on oncocytic or oxyphilic lesion, that is by definition a cell that has a prominent granular eosinophilic cytoplasm due to an increased mitochondrial content. The person who really described that cell originally was an individual named Ashkenazi Һฤthel, whose name has been applied to this, described the parafollicular cell, and perhaps for that reason alone, these lesions should not be called Һฤthel cell neoplasms. But also, if you speak to clinicians and you just say, you have a Һฤthel, your patient has a Һฤthel cell lesion, by FNA or by morphology, invariably they consider that just purely based on Һฤthel descriptor to be likely to be malignant when there are a wide variety of lesions that have so-called Һฤthel cells. So I have shied away from using Һฤthel and have used oncocytic cells, whether on cytomorphology, these abundant cytoplasm that translates into these brightly eosinophilic and granular cytoplasm. What that does generally, and maybe the nuclear changes occur prior, but usually in conjunction with oncocytic cytoplasm, there's an enlargement of the nuclei that maybe not in this particular instance can also include irregularities in size and shape and perhaps a suggestion of a diagnosis of papillary carcinoma. So these oncocytic lesions can be, or cells can be seen in a non-neoplastic, particularly in lymphocytic thyroiditis, Hashimoto's type, but also you can see them, you know, in cellular nodules with oncocytic cells, and of course in neoplasm, both benign and malignant, including papillary thyroid carcinoma. And here's an example of chronic lymphocytic thyroiditis, 2 different cases showing the clustering of these cells surrounded and permeated by benign lymphocytes and plasma cells, in which there's brightly eosinophilic granular cytoplasm and enlarged nuclei. And when you back off and look at the pattern, if you're ever considered or wondering or concerned about papillary thyroid carcinoma, the pattern of growth typically seen in this background of chronic lymphocytic thyroiditis is not typical for most, if not all, papillary thyroid carcinoma. So the follicular thyroid carcinoma oncocytic type, or the terminology used, oncocytic carcinoma of the thyroid, is a follicular thyroid carcinoma, predominantly, meaning more than 75% comprised of oncocytic cells, in which there's no nuclear features of papillary, no high-grade features such as mitosis and necrosis. These, again, are classified like conventional follicular thyroid carcinoma into capsule invasion only or minimally invasive, encapsulated angioinvasive, whether it's less than 3 vessels or more than 3 vessels, actually 4 vessels, or widely invasive. So the same classification. They're considered uncommon, less than 5% of all thyroid cancers. And the prognosis, just like follicular thyroid carcinoma, non-oncocytic, is correlated to the extent of invasion. I just want to note to you that these oncocytic follicular thyroid neoplasms, including carcinoma, can be synaptophizin positive. So if by some chance, and they may metastasize to lymph nodes. So if you have an FNA of a neck nodule that's in the lateral neck, that's clearly not midline and may not represent an inclusion, and it's oncocytic and synaptophizin positive, just remember that these follicular-derived, not neuroendocrine, not medullary, can be synaptophizin positive. And among the follicular thyroid neoplasm, perhaps this is the only one that metastasizes or may metastasize to lymph nodes as well as to visceral sites, including lung and bone. And because of their oncocytic nature, they're less avid for uptake of radioactive iodine, and that often correlates with a less favorable prognosis. So we dealt with invasion. I want to move on to cytomorphology. And the diagnosis purely on cytomorphology includes these different diagnoses. And as I mentioned before, in general, the bottom here, follicular adenoma cannot be differentiated from follicular thyroid carcinoma purely based on cytomorphology. And the classic defined neoplasm that's entirely or near entirely predicated on its nuclear alterations is papillary thyroid carcinoma. And of course, when you have papillae like this with fibrovascular cores and nuclear features, it becomes diagnostic for papillary thyroid carcinoma. But if you've looked at thyroid, you know that not everything with papillae is papillary carcinoma. And just because there is no papillary architecture doesn't exclude the diagnosis of papillary thyroid carcinoma. And the nuclear features is a constellation of nuclear features, not any one by itself, because inclusions, as I will show you, can be identified in things other than papillary carcinoma. And unless it has the other features, meaning nuclear enlargement and elongation with variation in size and shape, dispersed nuclear chromin or optically clear, clowning or overlapping, and nuclear grooves, you may make an erroneous diagnosis. And you may know the term orphan Annie nuclei. This comes from a paper in 1979 by Hapke and Daner, in which they likened the clearing of the nuclei in papillary carcinoma to the clear eyes of orphan Annie in this cartoon character. This is an artifact of fixation, and you will not see it on frozen section. So if you're waiting to see orphan Annie nuclei on frozen, you're going to miss the diagnosis. So here's the constellation of nuclear features. The total anarchy of the cells are not aligned in any particular location, but they crowd and overlap. There are irregularities in size and shape, some with semi-lunar shapes, very fine nuclear chromatin, some grooves, clear nuclei, inclusions. So these are the constellation of nuclear features, and the inclusion should look like these right here. This is an imagination from the cytoplasm. So it should retain a eosinophilic appearance, and because it's moving into the nucleus, it retains a distinct margination by the nuclear membrane. There are things that mimic intranuclear inclusions. You don't want to mistake those. But here, in addition, you could see the clear chromatin or orphan appearing chromatin. Inclusions, as I mentioned before, can be seen in other things than papillary carcinoma. Here is a beautiful inclusion, eosinophilic with sharp demarcation in a lesion that completely lacks the nuclear features of papillary carcinoma. So just because there's an inclusion doesn't make this papillary carcinoma. One needs to evaluate the context of the cells in which the inclusion is identified. And if you're starting to see so many inclusions, that you want to call this papillary carcinoma, remember, these are the least common of the morphologic features in papillary carcinoma. Some people quote less than 20% of cases will have inclusions. And so they're usually isolated when you find them. And again, this is not papillary carcinoma. So if you're seeing so many of these inclusions and they're white and they maybe have sharp demarcation, but not that membrane around it, beware that you may be dealing with an artifact of fixation that some people call bubble artifact. And of course, because the nuclear features are diagnostic, one can make the diagnosis on an FNA, as depicted here on the left, and a papillary appearance on the right. So that would be a Bethesda 6. Some homobodies are remnants of thyroid papillary carcinoma. There should be not only association, not always, with papillary carcinoma nuclei, but concentric lamination. So you can see them in association with viable tumor cells, or they may be isolated in the thyroid, indicative of intrathyroidal spread and perhaps lymphovascular invasion. Things that look like some homobodies but are not is inspissated colloid. So in contrast to the lamination seen here, the inspissated colloid lacks laminations. It's within the follicle, the center of the follicle. Whether it's oncocytic here or non-oncocytic, there are no nuclear features of papillary, and that is in sharp demarcation or distinction from true some homobodies. So don't mistake inspissated colloid for some homobodies and a diagnosis of papillary carcinoma. Some homobodies on rare occasion can be seen in association with lesions that are not papillary carcinoma. So the histologic subtypes, and again, this is from the upcoming WHO book, are listed here. There's not enough time to go through all of these, so I'm going to focus on just a couple. The most common is the classic, which includes, if you will, a microcarcinoma, which is defined as less than 1 centimeter. So what about immunohistochemistry? Does that help in the diagnosis? Well, we don't necessarily need to do these markers, so I just include them for completion. PTC, papillary thyroid carcinoma, follicular-derived tumors are negative for calcitonin and neuroendocrine markers, with perhaps the exception of synaptophysin in oncocytic follicular neoplasms, particularly follicular thyroid carcinoma. But purportedly, HbME1, CK19, and galectin-3 are diagnostic discriminators for papillary thyroid carcinoma. However, these are not specific. The staining can be patchy and weak even in papillary thyroid carcinoma, and there may be beautiful membranous staining in lesions that are not papillary carcinoma, particularly for HbME1. And an example is an adenomatoid nodule. You can see it's nodular, variably cellular, circumscribed but not encapsulated, no nuclear features of papillary carcinoma, but beautiful membranous staining for HbME1. So if the nuclear features are not diagnostic, don't be swayed by HbME1 staining as evident here. Here's a follicular adenoma. There are no nuclear features of papillary carcinoma, and it's nicely membranous HbME1. So yes, it's helpful in a diagnosis, but typically you should be able to make that diagnosis by cytomorphology. And parenthetically, the NIFPs can be HbME1 positive, but we don't classify that or put that in the classification of papillary thyroid carcinoma, as I will get to shortly. So I did want to focus on follicular variant of papillary thyroid carcinoma, which is a subset of papillary carcinoma with follicular pattern growth, absence of papillary architecture, and have nuclear features of papillary thyroid carcinoma. There's an encapsulated type, which is considered by the WHO as the second most common subtype after classic PTC, which includes microcarcinoma, and infiltrative de novo follicular variant of papillary thyroid carcinoma, which is considered uncommon. And just to let you know, this lesion, unrelated to a NIFP, behaves like a classic PTC. The problem over the past has been the lack of inter-observer consistency in making diagnosis. Two studies that really highlighted that included one by Rick Lloyd in 2004. There were 10 reviewers. The reviewers were sent 87 tumors, and primarily the paper was focused on the presence of concordant diagnosis. These are the 10 reviewers. These are the array of diagnoses made by the reviewers. Some were more swayed that these were papillary thyroid carcinoma variants. Others, and these included among the most esteemed thyroid pathologists in the world. So you could see there's marked variation even among the experts, where one was under 50%, one was 100%, and others, the same reviewer had a significant number that fell, in his view or her view, into follicular adenoma. So the concordant cumulative frequency of diagnosis was a horrific 39%. So the experts cannot agree among themselves what constituted nuclear features that warranted a diagnosis of follicular variant of papillary thyroid carcinoma. Tariq El-Sheikh at the Cleveland Clinic had 6 reviewers, 15 cases, and what he did was send the reviewers the cases on day 1, recorded their diagnosis, got the slides back, and then we sent them to the reviewers about 6 months later to see not only the inter-observer but intra-observer concordance. And the nuclear features in these lesions were not well developed, or were only focally developed, which now translates into an NIFP. But just for this study, there were 2 cases, or 13%, in which there were unanimous agreement. Majority agreement on benign malignant in 27, or 4 cases. Majority agreement on malignant in 8 cases. Intra-observer, meaning the reviewer's concordance with himself or herself varied from 17% to 100%. So the point being that even the same reviewer 6 months after the fact couldn't agree with himself or herself. So it just further strengthens the lack of consistency among experts in identifying or diagnosing follicular variant of papillary carcinoma. Some of the key issues to remember is that the follicular variant of papillary, at least in this schema, is uncommon to have RET PTC or BRAF V600E. It may have BRAF K601E, but not the V600E, which is one of the features that help define conventional papillary thyroid carcinoma. But these follicular variants have the mutational similarity to follicular adenoma carcinoma, meaning most of them are RAS mutated. This was affirmed in 2 different studies subsequent, to that schema. Both studies were out of Memorial Sloan Kettering, so where they reviewed these non-invasive follicular variants of PTC. In one study, there was no recurrence or lymph node metastasis. In the other, they were encapsulated or non-invasive with extremely low recurrence rates. The non-invasive ones behave similar to follicular adenoma. And in this study, in this group, there were infiltrative ones that behaved more like classical PTC. Tom Giordano, in a very detailed article published in 2014, further subdivided, he and along with numerous authors, tumors into 2 broad molecular categories: those with RAS-like mutations, which were non-invasive, and those that were invasive and had BRAF V600E tumors. We'll come back to this a little bit later. But I want to introduce the concept of NIFP, and I'm getting ahead of myself by a case study. This is a 44-year-old woman. She had a left thyroid nodule. She had an enlarged 2 lesions. One was 4.3 centimeter. That was radiographically a 𝒕𝒉𝒚𝒄 and a 1.2 centimeter 𝒕𝒉𝒄 lesion. FNA of the big lesion was a Bethesda 3. I don't know that they needled the smaller lesion. And because there were multiple bilateral nodules, they decided to do a total thyroidectomy. Just to if you're not familiar with TRADs, It's an American College of Radiology reporting schema for thyroid imaging. It's based on a constellation of features in which the radiologist assigns points so that the least points are typically benign and the most points are highly suspicious. So again, one of the lesions here, the smaller of the two, was a 𝒕𝒉𝒚𝒄 or moderately suspicious. So this is the 𝒕𝒉𝒚 4.3 centimeter lesion that proved to be a follicular adenoma. The molecular findings were HRAS positive and negative for BRAF and RET. This is the smaller lesion, which is the more interesting of the two lesions, and his gross depiction shows what appears to be a small 1.2 centimeter, circumscribed if not completely encapsulated lesion. And this section shows the encapsulated lesion. As you can see here, it's follicular pattern, more cellularity in some areas, a little bit more dilated colloid fill follicles in other areas. As we see the nuclear features, you begin to appreciate that there are areas with enlarged and elongated nuclei with dispersed nuclear chromatin. And I'll go through the nuclear feature criteria or point system for NIFP, but this equates to nuclear features that support a NIFP, including some grooves. There were no inclusions. In comparison to normal, because we also say these are enlarged and elongated, you can appreciate, and this is from the patient's own thyroid. The normal thyroid follicular nuclei are small, round, fairly regular, in not only in size but in shape, and dispersed or very hyperchromatic nuclear chromatin. The follicular adenoma had a little bit of an oncocytic cytoplasm, but again, the nuclear features were more akin to the normal thyroid and not enlarged and elongated with crowding and very fine nuclear chromatin. And then this patient also had an incidental microscopic papillary in which you could see fully developed nuclear features of papillary. So microscopic papillary, fully developed, follicular adenoma, no nuclear features of papillary, normal thyroid, and the 1.2 centimeter circumscribed if non-encapsulated lesion with nuclear features that are not fully developed, but moderately developed for papillary thyroid carcinoma. And on the basis of this one or these images, this would be a non-invasive follicular neoplasm with papillary-like nuclear features, or NIFP. And by now you know that because of the contentious issues that I showed you in reproducibility in diagnosis of follicular pattern thyroid lesions with some nuclear features of papillary, in which the experts cannot agree, plus the fact that these have an indolent biology, plus the fact that they have a RAS mutation, 𝒕𝒉𝒚𝒄𝒃 created a large panel of expert, both pathologists, surgeons, oncologists, and including one psychiatrist, which I'll explain in a little bit, and revised the nomenclature for the encapsulated follicular variant of papillary thyroid carcinoma, recommended the term NIFP, and it's reflected the subjectivity, as I showed you in the diagnosis, the fact that these are RAS mutated, so wholly different than most, if not all, papillary thyroid carcinoma, and they're extremely indolent biology, not warranting the designation as cancer. And that psychiatrist gave us an excellent talk about what it means to lay people to have a diagnosis of carcinoma. We as pathologists understand that there's papillary thyroid carcinoma, which can be quite indolent over long periods of time, but most lay people are not as savvy with knowing the fine details of cancers and the differences among even the organs, single organ system, different cancers. So for them, the life-changing impact carrying a diagnosis of cancer is significant, which led into some of the nomenclature change. The initial criteria for NIFP included an encapsulation or circumscription, no more than 1% or less than 1% true papillae. That means with fibrovascular core. So in the original criteria, papillary architecture was allowed, but not more than 1%. No Psammoma bodies. The presence of a Psammoma body, as I showed you, and non-inspissated colloid excluded papillary carcinoma, a nuclear score to 2 to 3, which I will define. Can have 30% or more of solid trabecular insular growth. That would put it into a different classification. No nuclear features of papillary of other variants, tall cell, columnar cell. no high-grade features such as tumor necrosis or mitotic activity, and no invasion. And in order to make the diagnosis optimally, the entire periphery of the tumor should be submitted for histologic review irrespective of size. The nuclear score, points are assigned for enlargement, crowding, and overlapping, which was present in the case I showed you. The nuclei were elongated, there were irregular contours, there were grooves, there were chromatin clearing, there were no inclusions, but this was a 3-point, each one gets 0 to 1. So in our case, there was at least a nuclear score of certainly more than necessary to make a diagnosis for nuclear features of papillary, which supported the diagnosis of NIF-P. The treatment generally, as documented in that paper, is conservative. It's not considered outright malignant, and therefore should be treated not as a malignancy, meaning lobectomy, and removing the term carcinoma speaks directly to the unnecessary therapy associated with that perhaps diagnosis, any financial costs, and most importantly, perhaps the psychological impact on patient and their family and friends when they have a diagnosis of carcinoma. Since the initial reporting of NIF-P, there are 3 published studies listed here that highlighted the presence of metastasis in tumors that had the diagnostic criteria for NIF-P. Based on that, there was a reevaluation and revision of the NIF-P criteria. So they need to be encapsulated with and/or clear demarcation, follicular growth pattern without any papillae. So now the criteria shifted away from any identifiers of papillary architecture. It still had to have a nuclear score 2 to 3, cannot be invasive, have a high nuclear grade, features such as tumor necrosis or high mitotic activity. Helpful in these revised criteria, but not necessary, although these days most FNAs have reflex molecular, which I'm always looking for, particularly when cases are submitted. Patients come to Moffitt for definitive surgery or therapy, and outside material has been done and sent for molecular analysis. It's very important to correlate that, but in this particular criteria, these tumors should not have BRAF V600E, nor any mutation associated with a high risk, such as TERT or TP53. Subsequent to that, an outstanding study out of Memorial, again, Ronnie Gossain's group, looked at the criteria for NIF-P. They described these as unifocal encapsulated PTC. These tumors fulfilled the criteria for NIF-P, had less than 1% papillary architecture, and no nodal metastasis. I mean, there were tumors that had more than 1%, and I think 10% or more that did metastasize, but the ones that had less than 1%, and quite honestly, when you're looking at a big tumor, determining what is 1% or less, or just a shade above 1% is problematic to the visual eye. But those cases had no nodal metastasis, and they had the genotypic profile of RAS mutated, but not BRAF mutated. So it all fits for what was NIF-P. And based on this, these authors, and rightly so, justified the original NIF-P criteria. So now we've reverted back to allowing for the presence of papillae, but they should be no more than 1% of the entire lesion. So we go back to the tumor that I showed you, the 1.2 centimeter lesion. What I didn't show you previously is seen here. In some sections, I told you if there's invasion, then it's malignant. So here's the same lesion, just in different sections, show capsular invasion and extension into the adjacent thyroid. Here it is on high magnification. So now we have a follicular pattern tumor that's encapsulated with capsular invasion. So what is the diagnosis and the nomenclature used for this? So capsular invasion equals carcinoma. So these are still or recommended to use the term invasive encapsulated follicular variant of papillary thyroid carcinoma, and in this instance, the coexisting lesion and maybe the pre-existing lesion is a NIF-P. So this is arising, in my view, from a NIF-P. So according to the upcoming WHO Blue Book, these encapsulated invasive follicular variants of papillary thyroid carcinoma are malignant, well-differentiated follicular-derived tumors. They're encapsulated, have exclusive or almost exclusive follicular architecture, meaning no more than 1% papillae. You can have papillae, no psammoma bodies. Nuclear features for PTC, typically not diffuse and well-developed, but moderately developed and maybe patchy or less than diffuse, and invasive growth. So these invasive encapsulated follicular variant, the PTC, and it's confusing because the terminology papillary thyroid carcinoma is used. But these are RAS mutated and behave like follicular thyroid cancers, not like papillary carcinoma. And they're staged or classified just like other follicular thyroid carcinomas. And this is not the staging classification used in any papillary thyroid cancers. So capsule invasion only, minimally invasive, which is what occurred in the case I showed you. There was no vascular invasion. They may have angio invasion, but not in this case, as I show you there. And again, you know, you use the same 4 or less or more than 4, and widely invasive, again, not in this case. So it carries the same terminology as the specific subtype of papillary thyroid carcinoma that I shared with you previously. But this is, in fact, a subtype of follicular thyroid carcinoma carrying the same biologic behavior potential as follicular thyroid carcinoma. If it's going to go bad, meaning metastasize, it's not going to go to lymph nodes, it's going to go to viscera. So a compare and contrast on the left are those tumors that arise in the NIFP, termed invasive encapsulated follicular variant of papillary thyroid carcinoma. These lesions typically have no intralesional sclerosis, no psammoma bodies. They tend not to have extrathyroidal extension. They're predominantly RAS mutated, but they may have PAX-A, PPR gamma translocation, low to no incidence of metastasis. But if they go bad, they behave like follicular thyroid carcinoma. The infiltrative, de novo, no pre-existing, coexisting lesion of follicular variant of PTC, usually non-encapsulated, typically has increased intralesional sclerosis. There may be psammoma bodies. There may be extrathyroidal extension. These are BRAF mutated or RET PTC and not RAS mutated. And if they go bad, they will metastasize to lymph nodes like PTC. And here's an example of one of those de novo infiltrative follicular variants of papillary thyroid carcinoma. It wasn't a big one. It was under 1 centimeter. But it's a nice example. There may be some circumscription, but it's infiltrative, no encapsulation, intralesional sclerosis, and nuclear features of papillary thyroid carcinoma without any papillae. So similar terminology, but wholly different lesions, both in terms of their molecular makeup and their potential for metastasis. And this is from the original article by Uri and co-authors, showing this schema of papillary microcarcinoma, BRAF, that may enlarge and become a classic PTC. The NIFPs, which are RAS mutated and follicular pattern with nuclear features of papillary, that when it's infiltrative is termed in maybe this needs to be changed, encapsulated invasive follicular variant of PTC. Again, this is from 2016, and the terminology has changed. And then the follicular growth, no nuclear features, RAS mutated follicular adenomas, which perhaps can lead to invasion of follicular thyroid carcinoma. The driver mutations in NIFP, they're mostly RAS mutated, but may include others. And I just highlight the BRAF K601E, which is unlike the BRAF V600E. It's adjacent to it, but it's a different mutation unrelated to papillary thyroid carcinoma. So if you look at the definition of NIFP written by Ronnie Gossain in the chapter in the WHO book, it's non-invasive, encapsulated, well-demarcated follicular cell-derived tumor, follicular growth, PTC nuclei, extremely low malignant potential. These may be small, meaning under 1 centimeter, so you can make the diagnosis or criteria the same, and they may have oncocytic cells, so you can get an oncocytic NIFP, again, at least 75%. Cytologically, these NIFPs are predominantly, this is again taken from the literature, Bethesda 3 about 30%, Bethesda 5 and about 24%, Bethesda 4 and 21%, and a outright malignant in a minority of cases. The rate of adverse outcome is less than 1% with NIFPs with no reported mortality. An inadequate resection may lead to tumor recurrence. and lobectomy is the treatment of choice, not with radioactive iodine. Again, this is an algorithm taken from that chapter, just to show you encapsulated whale-limited follicular pattern tumor, which is the primary subject of what I'm talking about. If there's invasion, and I showed you that from the very beginning, then it's carcinoma. It may be follicular thyroid carcinoma, maybe papillary thyroid carcinoma predicated on nuclear features. If it's questionable, you might use the terminology uncertain malignant potential. My reflex is to call it an adenoma. The clinicians understand that better. They feel more comfortable with it, and I try to be as distinctive as I can and not leave it in this category in which both the patient and the clinicians treating the patient are uncomfortable having a designation of uncertain malignant potential. If there's no invasion, but there's PTC-like nuclei that are well developed and diffuse with any papillae, then it's a papillary thyroid carcinoma. If there's this, the schema says not significant, I would say moderately developed and not diffuse, and the nuclear score is 2 to 3, and there's more than 1% papillae, it's a PTC. If there's not, and there's no exclusion criteria, then it may be a NIFP. And if the nuclear score does not reach a level of 2 to 3, then it's a follicular adenoma. The last slide I wanted to show you before concluding is just a very nice study by Tom Giordano, reaffirming the paper in Cell, showing that there are BRAF-like neoplasms and RAS-like neoplasms. The RAS-like include NIFP, follicular thyroid adenoma and carcinoma, and follicular thyroid adenoma and carcinoma with oncocytic features. And then the BRAF, which falls into the PTC. Poorly differentiated thyroid carcinoma may develop in the continuum from either BRAF mutated lesions or RAS-like. The same for anaplastic thyroid carcinoma, which may develop in conjunction or separate of poorly differentiated or now high-grade follicular thyroid neoplasm. So in conclusion, diagnosis of thyroid carcinoma is based on histologic criteria that I tried to show you. Although straightforward in terms of reading it in a book, if you deal with thyroid, it's not straightforward in terms of our interpretation and our colleagues' interpretation, both within our group and expert opinion. IHC can be helpful, but should not be used as the sole determinant in making that diagnosis of PTC. I showed you examples that are HBME1 with complete devoid of nuclear features of papillary. So you should not use HBME1 or CK19 or galectin-3 as your diagnostic determinant in the absence of nuclear features. I showed you some potential pitfalls to be aware of. NIFP replaces non-invasive follicular variant of papillary thyroid carcinoma with defined criteria. It may have papillae. It may invade, and in which that point the terminology is, in my view, unfortunate, but nonetheless utilized. Invasive encapsulated follicular variant of papillary thyroid carcinoma. And the reason I say unfortunate is because to the people who don't deal with thyroids all the time, both pathologists and clinicians, they're just going to see follicular variant of papillary thyroid carcinoma and not understand the nuance of what we're talking about, a tumor that's RAS mutated and has the potential to be behaved by follicular thyroid carcinoma. So that's the downside. The upside, if you will, is that it's carcinoma, and whether it's papillary or follicular, the treatment is going to be essentially the same. It may, if it's capsule invasion only, allow for conservative management, lobectomy, or if not, a total thyroidectomy and postoperative radioactive iodine. And then this invasive encapsulated follicular variant is a subtype of follicular thyroid carcinoma and should not be confused with a bona fide or de novo papillary thyroid carcinoma. And as I showed you, molecular findings are playing a greater role day-to-day in non-neoplastic and neoplastic lesions of the thyroid. And with that, I thank you, and I will stop sharing. Be happy to take any questions.
Dr. 𝒕𝒉𝒚𝒓𝒐𝒊𝒅, I'm going to amend something I missed at the beginning. The moderator of this conference is Dr. Sabrina Herrera. She's a young breast pathology specialist he made her fellowship in Baylor College, Houston, Texas. And now she works for the Clínica Las Américas in Medellín, Colombia. Okay, she's going to be moderating any questions for you, Dr. 𝒕𝒉𝒚𝒓𝒐𝒊𝒅, and for all the audience. Thank you for sharing this time with us.
Okay, I apologize for going over time, so hopefully nobody will hold that against me.
It is okay, doctor. Don't worry. Thank you very much for your excellent talk and all the information you gave us. Most likely, we will use this talk as a reference in the near future, for sure, because we usually see lots of thyroid specimens in our practice. So thank you again for sharing with us. We have a few questions. This is from a doctor from Medellin, Colombia, Dr. Cardona. He would like to know which is the incidence of Bethesda 3, 4, and 5 in your hospital, and if you have any advice to make low the Bethesda 3 reports. And thank you for the excellent talk.
Thank you for the question. I wish I had the answer to that. I don't, off the top of my head, know the incidence. I'm not a cytopathologist. I don't deal, on occasion I do, only because cyto comes with the case. So I'm going to have to pass on that. I'd be happy to get you those numbers and send them to either Dr. Herrera, Dr. Mejia, once I can get them from our cytopathologist.
Thank you very much. Yes, here we need to see, we usually see the FNAs and also the specimens, so in our routine practice. So that's why we ask. We don't have many cytopathologists here in our country.
I would just say, because I work in a cancer center, the majority are going to be either Bethesda, some are Bethesda 3, but 4, 5, and 6. The patients come here for tertiary care. So the percentages of thyroids that we see tend to be the atypical ones and the malignant ones, both differentiated, poorly differentiated, and anaplastic.
Okay, doctor, we have more questions. Considering the risk of thyroid cancer with radiation exposure, is there any morphological difference among those cases related to prognosis?
Well, at the time where teenagers were treated for acne with radiation, which was last century, typically those lesions occurred decades later and were more conventional papillary thyroid cancers.
Okay.
The people who were exposed to high dose radiation, like at Chernobyl, the temporal sequence occurs in a much shorter time because the dosage of radiation is that more significant. And often those are more aggressive variants like solid type of papillary thyroid carcinoma. Hopefully not many of us are not exposed to radiation.
Thanks God. Okay, is there any use, according to your point of view, for thyroid nodule core biopsies?
Okay, that's a good question. No, I don't think there's any use for that other than that it's a follicular thyroid lesion. Core biopsies are good for patients who have clinically aggressive tumors that may be poorly differentiated or anaplastic, because particularly for anaplastic, patients may go on protocols. And having said that, the differential diagnosis for typically an older person with a rapidly enlarging thyroid-based lesion is an anaplastic thyroid carcinoma and a large cell lymphoma. So core biopsies in that clinical scenario make sense. I just had a core biopsy. There was a review from the outside, and all you could say, if there's no nuclear features of papillary, is that it's a follicular lesion. You don't know if it's a cellular nodule or a true neoplasm, and if it's a true neoplasm, you can't differentiate an adenoma from a carcinoma. So in general, with some exceptions, there's very little use of a core needle in a conventional looking clinical lesion. I mean, it's a papillary carcinoma, you can make a diagnosis.
Okay, another question. Can you tell us something about the criteria to differentiate between benign inclusions versus papillary carcinoma in metastasis to lymph nodes? Okay,
so there can be a discrepancy between the primary and the metastasis in terms of the histomorphology. And not infrequently in lymph nodes, the nuclear features of papillary are not fully developed, but can be quite bland. So if it's a lymph node in the lateral neck with thyroid follicular epithelium, it can't be an inclusion embryologically. It has to be metastasis. So if it has bland nuclear features and an inclusion, to me, in a lymph node that's lateral to the great vessels, that's metastatic papillary carcinoma. If it's midline, then it could be an inclusion, a thyroid benign inclusion in a lymph node that may have an inclusion, as I showed you in the follicular adenoma. But the criteria for benign inclusions have to be fulfilled, meaning that there are few thyroid follicles. It's in one lymph node. If it's in multiple lymph nodes, then it's metastatic cancer. It has to be in the capsular or subcapsular area, and there has to be no nuclear features of papillary. So it all depends on where the lymph node is located. And in the criteria that I couldn't speak to today, because I already went over time, were metastatic tumors and differentiating it from inclusion, thyroid benign inclusions.
Okay, thank you very much, because here we sometimes have very frequently thyroid frozen consult and also lymph nodes. So, for example, you can see samoma bodies or maybe calcifications, and you get scared, and maybe it's just an inclusion,
Well,
a benign.
if I saw a samoma body in a lymph node, then that would be highly suspicious, if not outright diagnostic for metastatic cancer.
Okay, we have another question. It's about frozen consult too. What precautions should you recommend if we do a frozen study of thyroid and we don't see like nuclei characteristic for papillary carcinoma of thyroid, and in the histopathologic study you discovered that you had a papillary carcinoma?
Okay, so we don't do frozens on thyroids here. And I would discourage doing a frozen on thyroid, but the clinicians, the surgeons can be quite adamant. It's very challenging to make a diagnosis of cancer on a thyroid. So if there's a prior FNA that's Bethesda 6, there's no reason to send a frozen. You have a malignant diagnosis, and they should just do it. You know, if they're planning on total thyroid, do the total thyroid. If there's an equivocal FNA and you have a nodule and you're doing a frozen, the best that you can do is, you know, take a lesion, also do a touch prep, because the touch prep may be the better cytology discriminator for making the diagnosis. You know, because I'm not a cytopathologist. If I'm doing that, I want a pap smear and a 𝒕𝒉𝒚𝒄 to help me make the diagnosis. But on a frozen, you know, it can be very difficult, and often you have to defer. And just because you find you can't make the diagnosis on frozen, but you can on permanent, doesn't mean that it was a mistake on frozen. There's about a 10% deferral rate that's acceptable for thyroid frozens. But I would go back to the fact that I wouldn't do a frozen, you know, as best, especially in trying to discriminate a nodule or an adenoma from carcinoma.
Okay, we have our last questions by now. When do you do molecular ancillary tests when you have thyroid carcinoma?
Okay, so we have the immunostain BRAF. It's a complicated stain, but I often reflex to that if I'm concerned that there are nuclear features and I'm trying perhaps to decide whether it's a NIFP or papillary cancer. If it's BRAF positive, then it takes it out of a NIFP. If it's BRAF negative, it doesn't mean it's not PTC and doesn't make it a NIFP, and then it's a morphologic diagnosis and can be quite complicated. So those are the times when I may reflex or order molecular, or, you know, if a patient's on a clinical trial, and many clinical trials at Moffitt, and they need, you know, certain molecular analysis to use for the clinical trial, then we'll reflex to molecular, but not necessarily to make a diagnosis, but for clinical trial purposes.
Okay, we don't use it here in our routine practice, so yeah. We wanted to know.
I think more and more FNAs are being sent consistently, at least in the United States, for molecular thyrosec and Afirma for assistance in trying to help. But, you know, I could tell you, you know, sometimes you get this, you know, 50 to 70 or 70% risk of malignancy, and it turns out to be a nodule. So, there's not necessarily helpful in terms of percentages, but if I know if there is a particular mutation or translocation, that might be helpful in making a diagnosis.
Okay, thank you very much. I think we don't have many more questions. I want to tell you that we have people from Colombia, but also we have people from Mexico, Panama. We have people from Peru and Ecuador. So thank you very much for the excellent talk.
Thank you for the invitation, and everybody had a good evening.
Thank you.